Joe. Okay, yes, so just checking, are we all good to go? I think there was a few people having some issues with some sound, but I think it might have been, yes, okay. There's other people that do have audio, so I think we're good. Okay, so I'd suggest that if anybody's having trouble, you just try logging out and then logging back in again. The old turn it off, turn it back on system, see if that works. Thank you for the introduction, Joe. As Joe said, I'm Simone Dorsch, and I am presenting this lecture, I guess, because I have quite a few years of clinical experience in using electrical stim, in particularly for people who after stroke, but I've also worked in traumatic brain injury. I've had a very small amount of experience using it in people with incomplete spinal cord injury as well. As part of my PhD studies, I also did a randomized clinical trial looking at using EMG-triggered electrical stim in the upper limb in people who are very, very weak after stroke. And I've run workshops on electrical stim as well. So that's my kind of background in electrical stimulation. We've started the recording. That's the reminder slide in case we've forgotten to do that. Before we get into content, I would like to acknowledge the traditional owners of the land that I'm on. I'm in the area known as North Sydney, and this is the land of the Camaragal people, who are part of the Eora Nation, who are the first peoples who lived within the Sydney Basin area. So I'd like to acknowledge all elders, past, present, and future, and pay my respects to them. The learning outcomes for this lecture are that we would be hoping that you feel that at the end of this lecture you can outline evidence for using electrical stim, be aware of some sort of the more common straightforward applications of electrical stim in the upper limb after stroke, and also have some awareness of what the parameters are and what the reasons are for choosing different parameters when you're setting up electrical stim. And we'll go through some strategies for troubleshooting when you're having trouble getting a muscle contraction. So we're going to have a look at the types of electrical stim to start with, then evidence, look at some of the more successful intervention protocols, and then in a bit more detail about the application and the physiology behind the parameters and troubleshooting. So types of electrical stimulation to start with. When you have a look at the literature, there's a lot of different words used for the same thing, and I think it just helps to create a lot of confusion about what exactly it is that people are doing. So I think it's probably easiest if we talk about plain electrical stimulation, being the electrical stimulation where the machine is set, that's doing its on-off duty cycle, and so it's sometimes called cyclical electrical stim or just plain electrical stim. To confuse things, sometimes people call TENS stimulation that is causing a motor contraction, but probably more commonly TENS is used to apply to transcutaneous electrical nerve stimulation that is for pain relief, that uses a lower frequency than a motor frequency. But you do get that sort of overlap of terms, which just helps to kind of create more confusion about things really. But anyway, we'll talk about plain electrical stim, that's really those top four. And then we have functional electrical stim, and that is where electrical stim is used in combination with somebody doing a task. And so in the upper limb, it might be that they're doing a reaching and grasping task, and they haven't got very good wrist extension, and so they've got electrical stim to help with their wrist extension while they do the task. And it's really used there in the context of allowing people to do more practice, because the electrical stim is helping them to do something that they can't do very well without the electrical stim, or maybe they can't do it at all. Then we have triggered electrical stim, and this is electrical stim where there's some kind of trigger has to be reached before the stimulation starts. And there's different types of triggers that can be used. You can have an EMG triggered electrical stim where somebody has to produce a certain amount of electrical activity themselves in the muscle. And once they reach a threshold amount, then the electrical stimulation kicks in. Position triggered, so there's some kind of trigger and it's reliant on them moving to a position, and then the electrical stim kicks in. Pressure triggered, so some kind of pressure. This is very commonly used in the lower limb for getting dorsiflexion in swing. And then I'm sorry, I haven't added into that list, but also just a hand triggered one as well. So something where you might have a therapist using a hand trigger while after the stroke survivor attempts a movement, or the stroke survivor themselves using their intact hand as a hand trigger. So we'll kind of classify all that top group as plain electrical stim. Then we've got the functional electrical stim where it's being done in combination with a task, and then various types of triggered electrical stim. So the plain electrical stim, it has a preset on-off cycle. The stroke survivor can be quite passive and just have their hand going up and down while they sit there. But we'll talk about ways that you might sort of set that up to encourage more activation from the person who's receiving it. So there's an example of somebody having just plain electrical stim at a preset cycle to their wrist extensors. And here we see electrical stim in combination with somebody doing a task. So in this, the stroke survivor is reaching to grasp the cup, and the electrical stimulation is assisting their wrist extension and their thumb abduction to help them to get into position to grasp that cup. So functional electrical stimulation. Triggered electrical stimulation, we've got various types there. Position, EMG triggered, hand triggered. We had pressure triggered in that other list as well. This is an EMG triggered device. So you can see there's 3 electrodes, and within those 3 electrodes, there's 2 that deliver the stimulation, and there's 1 electrode that reads EMG activity. Or sometimes different machines do different things, or sometimes you have a reference electrodes and the same electrodes can read EMG activity and deliver the stimulation. But you've got 2 things going on with the machine. The machine can measure EMG activity and deliver a stimulation, and so you set a threshold of EMG activity that the person produces before the stimulation is provided. This is an example of position-triggered electrical stimulation. This device is called the Smart Arm. It was developed by Ruth Barker, a Queensland-based physiotherapist, and the purpose of the Smart Arm is to provide a means of somebody particularly practicing forward flexion and elbow extension when they have a very weak arm. And so you have a device that makes it very easy for them to move because there's very little friction. There is some feedback from the machine, but the electrical stimulation here is applied to the triceps and it's position triggered. So it's expecting the person to initiate the movement, and when they get to as far as they can get, which will be a threshold that's been set, and then the machine will kick in. And then within we've got all those different types, but then you can have one channel or 2 channels coming from the machine. So here the example that we looked at is just a single channel being applied to the wrist extensors there. You can have a dual channel setup, and so that functional electrical stimulation example that we looked at, there's 2 channels. There's 1 channel going to wrist and finger extension and 1 channel going to thumb abduction. In a dual channel setup, you can have both channels working synchronously, and so that's what you would want in this functional electrical stimulation example. Or you might have a delay there as well, so you can have it so that one kicks in a little bit later than the other one. Or you can have an asynchronous or alternating dual channel, and this is a setup to help to help reduce swelling in the hand. And so you've got the machine bringing you into wrist and finger extension, and then a bit of a break, and then wrist and finger flexion. So it's really just to try and sort of stimulate a muscle pump. And then you have various types of electrodes. So just some examples of different types of electrodes, and you'll choose the different types of electrodes according to the shape and size of the muscle that you're delivering the stimulation to. Okay, Joe, I might just pause quickly there because I can see somebody's raising their hand, and I think there's a few things in the Q&A. Is this a good spot to have a quick pause before we start on the evidence?
I think it is, Simone. There's been a couple of interesting questions coming in. We had a question from Katrina, and Katrina was asking, I think probably many people would have this question, if there's a cost-effective stimulation machine, a brand that you may recommend, Simone, and I guess you can buy it from many different suppliers, but what do you think?
Okay, there's a machine here that we use here at the university for teaching the students, but it's used very commonly clinically. In Australia, it's called, well, what is it? It's called exactly. It's a NeuroTrack rehab device, and it costs somewhere in the order, I hope I'm not making that up too much, somewhere in the order of $200 Australian. So which is, you know, pretty reasonable. They're very durable. They actually, this device actually has a hand trigger too. So when I talked about a therapist having a hand trigger, you can provide a hand trigger to this device. And we'll show you an example of a study that used a setup like that when we're talking through the evidence.
I think that's really useful, Simone. There's another question, and the person is asking, where do you place the reference electrode for the EMG triggered electrical stimulation?
If you have a reference electrode, and so that's just trying to distinguish between sort of noise and EMG activity, you just want to place it away from the muscle that's away from the muscle that's working. So just have a look at what's sort of suggested on the instructions for the machine, but generally it'll just be, you know, maybe on the other arm or up somewhere else on the trunk, maybe if you've got it on the upper limb. So just somewhere that's going to give you sort of reference for other muscles that aren't doing anything at the time.
Simone, another attendee is asking if there's a resource for ES electrode placement, or I'm wondering if you just sort of place in different places and see how you go with the stimulation.
We'll have a talk. We'll have a bit of a talk through some of those main principles about placement as we go. I
think that covers most of the questions for now, Simone. So it might be good to continue on.
Okay, we'll power on into the evidence. Okay, so evidence. We're going to cover evidence in these following areas. We're going to use the Australian guidelines. So the Stroke Foundation in Australia I'm not just being parochial, they are very, very good guidelines. And you know, there's actually a review of guidelines, and the Australian ones actually score the highest on the sort of the quality rating scale that's been applied. They're very clear to read because they break things into sort of task by task and impairment by impairment, and what's the evidence for addressing those various levels of the ICF. So we'll have a look at those guidelines, and we'll also have a look at some of the detail from the systematic reviews and clinical trials that are used and that help to inform those guidelines. So the guidelines will give a strong recommendation where there is evidence with certainty of benefit. They give a weak recommendation where there is evidence, but there's a lack of certainty around that, around the evidence. And so the way it is worded in these stroke guidelines is, if it's a strong recommendation, this is something that you should be doing. And so, as you can imagine, for most things, task-specific practice really always gets a strong recommendation. And then a weak recommendation is something that you may be doing. So there's less certainty. So none of this evidence actually reaches a strong recommendation, but it is areas where there's only some evidence. So starting with strength, in these guidelines, there's a weak recommendation that for where there is less than anti-gravity strength, so grades 0, 1 and 2, electrical stimulation may be used. And if we have a look at a systematic review that has helped to inform that guideline, there's a systematic review of 16 clinical trials. That's just over half of them of the upper limb. And it shows a modest effect on strength. And in this review, they're looking at plain electrical, just the plain cyclical on-off plain electrical stim. The effect size is about roughly 0.5, which would be considered a moderate effect size. And it's using a standardized mean difference, which is really just a statistical value that you have to use when you're combining data that has measured an outcome in different ways. So that would be considered a moderate effect size, but the 95% confidence interval is not very precise. So it sort of ranges from being a low effect size to a sort of a high moderate effect size. And so this is the forest plot looking at the outcome for strength, and you can see that's the effect size here, the standardized mean difference of roughly 0.5. And see favors the experimental, which is the electrical stimulation. For upper limb activity outcomes, there's a weak recommendation as well that for people with mild to severe arm or hand weakness, that electrical stim in conjunction with motor training may be used. So the recommendation here is really for functional electrical stimulation. And now, because now the outcome that we're looking at is upper limb activity rather than strength. And there's a systematic review done just looking at trials that are of functional electrical stimulation. And the outcome that they're looking at here is upper limb activity. It's got 8 trials. The effect size or the standardized mean difference is 0.7, which is sort of getting towards 0.8. Anything considered at 0.8 is considered large. But if you have a look at the 95% confidence interval, the range does go from a sort of a low effect size through to a large effect size. So there's not very much precision around that result. There's quite a large range there. And that's the forest plot. So you can see the studies that have been included there. And here's the standardized mean difference of about 0.7. Okay, so it is in favor of the functional electrical stimulation. For shoulder subluxation, we have a weak recommendation that for stroke survivors who are at risk of shoulder subluxation in the first 6 months, that you can use electrical stim, or you may use electrical stim to prevent or reduce subluxation. And we'll have a look at the setup for that. For swelling, we now have what in these guidelines is the lowest level of recommendation. It's a consensus-based recommendation, which is at the level of expert opinion, which, as we know, is always the lowest level of evidence is expert opinion. But we do have a consensus-based recommendation that for people who are at risk of developing swelling, those some other strategies, but also has electrical stim. And I'll show you the RCT that is based on. So it's based on one RCT that looked at using electrical stim, a dual channel setup. So you can see the one channel going to wrist and finger extension, one channel going to wrist and finger flexion, and you work one side, have a bit of a break, work the other side. So you're really reproducing a muscle pump. And it was shown in this small trial to be effective. The comparison intervention was actually elevation of the upper limb. So it was more effective than the elevation, whereas you can think clinically, actually, probably what would make sense to do would be to do the dual channel electrical stim to provide that muscle pump, and to elevate the arm at the same time would maybe be what you might do clinically. So that was the setup for using it to prevent or reduce swelling. Yeah, so why not add those two things together, the electrical stim and the elevation. There's also a consensus-based recommendation for contracture in those guidelines that people are at risk or who've developed contracture for active motor training or electrical stim. But again, this is the lowest level. And this is really just thinking about the fact that if people are at risk or have developed a contracture, it makes sense for them to be moving as much as possible. But if they're too weak to move, then electrical stim can help to provide movement. But this is not really evidence. This is at the level of expert opinion here. But we do have some evidence which gives a weak recommendation for stroke survivors with shoulder pain to use electrical stim to manage shoulder pain. And I had a look at the systematic review that informs this guideline, and it's a real mixture. It's hard to draw anything very consistent. Some trials used a TENS stimulation, which is a lower frequency stimulation, the more pain relief type of stimulation, and some did use plain motor stimulation, electrical stim. Some trials did it for 20 minutes a day, some trials did it for hours of the day. So it's very hard to sort of draw out from that what was the really kind of most effective sort of protocols. There is also a weak recommendation for the use of electrical stim amongst the adjunct therapies that can be used for spasticity. And if we have a look at the systematic review that helps to inform that guideline, what we see here is a small effect, but only in the studies that combined electrical stim with other therapy. So if you have a look at this forest plot, you can see the left-hand side here favors the experimental group, and it's for reducing spasticity. And it does give a statistically significant result. It sits off the zero line. But the result is 0.35, and it's got a fairly wide 95% confidence interval. But I think the important thing to note here is that when it was just electrical stim alone, it sits on the zero line. It didn't have an effect. So it's electrical stim in combination with other therapy, which was a mixed bag of other therapies, so not very clear sort of protocols there. I'm going to summarize those then in this table. So thinking about whether there is evidence or not, and what is the level of that evidence. And so what we have is this summary. So yes, it appears it does make a difference at the level for strength and for activity, but it is a weak level of evidence. Spasticity, it's a bit of a question mark because it feels it has to be combined with other therapy. Contracture, consensus advice for swelling. Weak levels of evidence for subluxation and pain at the shoulder. Maybe I'll finish the evidence section, Joe, and then we'll have a little pause there. If we pull out some of the detail about some of the trials that have been more effective and I'm pulling out strength and activity here because I think this is what we really want to change in the upper limb. If we have a look at the detail of some of those studies, I think what is needing to be noted is the dosages of practice with the electrical stim are quite high. We're looking at, so 60 minutes, 45 minutes, 150 minutes a day, 45 minutes a day here, about 12 to 16 weeks, 90 minutes a day. So I think this is telling us something about the protocols that have been more successful, is that the dosages are quite high. And that's something obviously that we need to keep in mind if we're wanting to really maximize the benefit of electrical stim. And I'm just pulling out one study in particular, which did show a better outcome for the intervention group. But I think because it started with patients with upper limb paralysis or very little movement, and they are our hardest group of stroke survivors to really help to get their upper limbs moving and more functional. So in this group, the people that had the experimental intervention received the normal therapy, and then 45 minutes a day of functional electrical stim, so done within the context of doing tasks. But you can see it's quite a long intervention period. And in this study, it was hand triggered. So it was a device which could have been a device like this, but one with a hand trigger. And so what happened was that the stroke survivor needed to voluntarily attempt the movement. And once they had attempted the movement, then the therapist would use the hand trigger and the stimulation would kick in. And they had two phases. So first they worked on reaching and they provided, and they also applied the electrical stim to multiple muscles as well. So they did a reaching phase, and when somebody got, I think the way they expressed it was when somebody could actually get their hand in front to their workspace, if you like, in front of them. Then they went on to phase 2, which was grasping and releasing tasks. And again, they applied to multiple muscle groups and with the hand trigger, so that the stroke survivor was always attempting the movement first. So I think we've got some common themes here when we think about the successful intervention protocols. They are often some really quite large dosages of application of electrical stim, triggered, though that's not that clear, but certainly in some of the ones like this, and triggered because then it means that the stroke survivor has had to try and do something. They're not just passively receiving the electrical stim. And multiple muscle groups is also another feature of some of these more successful trials. Joe, shall we have a little pause there before we go in and start to talk about the various different sort of easier common applications?
Probably a good idea, Simone. There's quite a few questions lining up for you. Lisa was asking if you feel that it's safe for clients to use the eStim or FES as part of their home exercise program alone, or if you feel it should be done in the presence of a therapist.
No. Okay, well, and we'll talk to this a little bit, Lisa. These are very safe machines. And when we look at those dosages of practice, how are you going to get those dosages of practice if it's a sort of a one-to-one done with a therapist? In a normal kind of clinical environment. So definitely teach the machine, the use of the machines to stroke survivors, teach it to their families. If they're interested in buying their own machine, if they have those sort of resources, they're not super expensive machines. So definitely we should be teaching electrical stim to stroke survivors and their families.
Lisa had a follow-up question there, Simone, as well, asking if FES is only suitable for stroke. Would you recommend it for other people with acquired brain injuries?
Yes, definitely. Yeah. Anybody with a sort of an upper motor neuron lesion definitely can be used. Yeah.
Amy asked an interesting question about subluxation. I think you'll be coming on to this in the future slides, Simone. But she's read that the range of application times is between 30 minutes to 6 hours. She wonders what the minimum length would be for electrical stimulation for the prevention of subluxation to be effective.
I don't know if we really have that kind of level of detail in the trials that have been done, but I think if we think clinically about the purpose of applying it for shoulder subluxation, you're using it to provide support around a shoulder that has very weak muscles, and you're using the electrical stim to provide more support, to hold the humerus better into the glenoid fossa. And so it probably makes sense for it to be on all day. So I think if we kind of think about the clinical reasoning for that application, that it's not a treatment session kind of application. It's something probably that we should put on in the morning, and it gets taken off when the person goes to bed. So that's probably really on when the arm is more dependent when the person is upright. Anyway, we'll have a bit more of a chat about shoulder subluxation.
Simone, there's a good question here asking about how long you'd continue trialing ES. I think that this person asking might be thinking on people with very weak or paralyzed muscles. How long do you keep trying if there's been limited or no effect? What's your clinical experience here?
Oh, that's
It's a hard one.
That's really tricky, isn't it? Because, you know, you think about your clinical experience and the people you've seen who get muscle activity back, you know, 6 months after their stroke, 2 years after their stroke. It's a very, very difficult question. I actually think that it is often harder to apply electrical stim successfully as people become more chronic after stroke. And I assume that's because there's more, and you get more kind of breakdown of what's happening peripherally too, you know, and that sort of, we know that there's kind of less excitability of motor units and things sort of later after stroke. So I think some of that can sometimes make it harder for it to be as effective as it is more early after stroke. But I think that's a really hard question, and I don't think we are probably the ones that should be answering that question. I think that's probably should be the question that gets answered of the stroke survivor. You know, do you want to persist with this thing that has been shown to have some evidence? What are your priorities? How long do you want to keep going with it?
Thanks, Simone. I think we might continue on. We have quite a few questions on contraindications and precautions, but I know that's coming up. So we'll leave those questions for now, and I'll ask them again if they don't get covered in that section. Thanks, Simone.
What I'm going to cover is some of the kind of the more easy upper limb applications of electrical stim. So if we have a look here, we've got elbow extensors. So getting it onto the triceps is a relatively easy application. Elbow flexors, which I'll show you in a video. Wrist and finger extension is probably the most easy application. Thumb opposition is actually quite an easy application as well, and we'll show you a video of somebody getting thumb opposition, but also on their hypothenar eminence to get opposition of their fifth finger as well. And shoulder flexion is actually a relatively easy application as well. So looking first at the applications in which we're aiming to increase strength of muscles, some of the other, I guess, principles that you would want to follow would be that you make the movement as easy as possible. So if you have a look at these men here, they've been this man's been set up for elbow extension, but you can see his forearms being sort of raised off the table, so there's no friction to the movement, and his hands on a wheelie thing. So it's really easy for his arm to move when the electrical stim kicks in. And same for this person who's been set up to do forward flexion. The other principles that you really want to follow are the principles when we think about what's happening with loss of strength after stroke and we have a loss of central drive to muscles. You need to set up the electrical stim to try and engage the person as much as possible and get them to try and activate their muscle as much as possible with the electrical stim, because the electrical stim is, after all, just a peripheral stimulation, but what you need for increasing strength is more central drive to the muscles. So it makes sense, if you want to really maximize its effect on increasing strength, that you do anything that you can to get the person to practice with the machine. And so some of the principles you would follow there would be providing external cues to movement, because we know that people move much more successfully and much more effectively when they have an external cue. So this person is bringing their hand up to touch the straw, and it might be that the electrical stim is actually doing most of that movement, but then that gives them that sort of focus, and they can also think about trying to get their hand up to the straw. As the machine kicks out, then with the straw there, then the instruction could be, you know, keep your hand against the straw, keep your hand against the straw as long as you can when the machine stops. You know, so if you have those external cues, then you're going to be much more successful at increasing sort of voluntary activation. So having external focus cues. We're going to have a look at a couple of videos of a few setups, but we have had, of course, at the last minute, just as we were starting here, we had a few problems with some of our videos. So I'm just going to, Joe, can you give a yell if for some reason the screen share goes a bit funny and we can't see this well? But otherwise, I'm just going to pull up the videos, but not those embedded videos that seem to stop working so well.
That's working well, Simone. Working
beautiful.
well.
Thank you, Joe. So what you see here, I'll just pause it for a tick, is a dual channel setup. And so there's electrodes on elbow flexors and electrodes on elbow extensors. There's a cue for the movement here, and I think there is some sort of cue for his elbow extension as well. But you can see what this man is doing then is practicing flexing his elbow with the machine and extending his elbow with the machine. He got a little bit of help from his relative there. Okay, so you can see the machine is now certainly helping him to extend there and now helping him to flex, but his instructions are to work with the machine and to work towards some of those cues that have been set up for him. I think we'll just see him come out again into extension in a tick. Yeah, somebody's showing that it's about to come on, but try and move with the machine. So that's a two-channel setup with alternating, but for the purposes of increasing strength. I might just pull the videos up here just to know that we've got them safely working. So in this, I'll just pause this a tick, but in this video, what you see is you've got again a two-channel setup where what's being activated is the thenar eminence here, but also the hypothenar eminence. So what you see when the machine kicks in is you see the thumb coming abducting, but also coming across into conjoint rotation, and also conjoint rotation at the hypothenar eminence too. So there's the machine kicking in now. And you can see it's a dual channel setup with both channels working synchronously in this instance. Okay, so I'll just take it back there to where, yeah, so that movement is coming really just from the electrical stim with both channels working together. And I'll pull it up where I know it's safe here too. So what you have here, I'll just pause it for a tick. This is functional electrical stimulation here. So the person is reaching for a cup and the electrical stimulation. So again, we have a two-channel setup where it's working synchronously, and you'll see it's helping them to achieve wrist and finger extension and thumb abduction conjoint rotation so that they can reach to grasp the cup. And so that's very much the context of functional electrical stimulation, where the electrical stimulation is helping that person to achieve a movement that they cannot otherwise achieve. And there's a couple of examples there also of really just the thumb conjoint rotation being used while somebody reaches to grasp or grasps an object there. Okay, so I'll just flick through to the following slides there. Okay, so in this application, we've got somebody doing elbow extension. It's EMG triggered. And so this is a setup where you have 3 electrodes and one of them reads EMG activity and the other 2 in this machine. One machine reads the EMG activity and the other 2 electrodes deliver the stimulation. And so that's the That's when the person has triggered it, then they get the elbow extension from the stimulation. So where EMG triggered works very well is when you've got somebody who's maybe what you might call pretty much a grade 1 on a manual muscle test. So they've got some flickers of muscle activity, but maybe they can produce a little bit of movement, but not much. And so you set that as the threshold. When they've reached that threshold, then the stimulation kicks in and gives them the movement. So it's quite good sort of feedback kind of system that they've got to that threshold and the stimulation kicks in. And with a lot of those devices, you can set it. The machine will make the threshold higher, so the person has to work harder. If they're achieving a lot of success, then they have to start to work a bit harder. If they're not reaching the threshold, it might drop it down lower again. So there's some relatively cheap devices that you can use for EMG triggered electrical stim that are really quite useful and easy to use. Okay, shoulder subluxation, here we are. So if you have a look at this man's shoulder, you can see that there is a subluxation there. Okay, so you can see the lack of togetherness, if you like, of his shoulder. And so at the moment, the electrical stim is not on. Okay, so when I flick to the next photo, the stimulation is working, and you'll see that he gets elevation of his humerus, and now the shoulder joint is actually looking much better, and actually effectively sort of removes the subluxation pretty much there. So that's the elevation of the humerus. The position of the electrodes for shoulder subluxation is on so that you can't see it that well, but there's an electrode on supraspinatus and an electrode on posterior deltoid. Now we're getting, I hope you got your brains in gear. We're going to talk physiology for a little bit, because we need to understand some of the physiology if we're going to be the best we can be at manipulating the parameters of the machine. But, I'm no physiologist, and I don't fully understand what's happening here, which I think sometimes I think maybe that makes me quite good, because I'm sort of struggling to understand it myself a bit. But I will relate my understanding of it to you, and what we will think about then is how we relate that to the changing the parameters on the machine. If we think about a normal muscle contraction, in a normal muscle contraction, you have the action potentials travel down and through your motor neurons, and each motor neuron activates a group of muscle fibers, and each one of those is a motor unit. Okay, so you have your muscle made up of all these motor units that are a motor neuron plus the associated motor fibers, muscle fibers. You have different types of motor neurons, and so each motor unit is made up of different types, and you have type 1, if you remember your university days. Type 1 is your fatigue resistant motor units that don't produce as much force. Type 2 produce more force but fatigue much more easily. And so this is what happens if you remember Heinemann's principle. As you are producing force in your muscle, you will send down the action potentials according to the force you need to produce with the muscle. You will start with type 1. If you need to produce more force, you will recruit type 2 motor units. Okay, so that's just important to note, because what happens with application of electrical stim, if you have a look at, so here's our electrode, here's our skin, here's our peripheral nerve. Have a look at the type 2 motor units, the big white ones. The type 1s are the little red ones. It is easier to stimulate larger fibers. Okay, so the electrical stim will more preferentially stimulate type 2 motor units, which is one of the reasons why you sometimes see quite rapid fatigue. So sometimes you're getting a very, very good stimulation, but it doesn't last very long. And so that's one of the reasons why is because you're getting more of those type 2, which are not so fatigue resistant. The other thing, if we think back to normal muscle physiology, is that there's lots of motor units being recruited according to the force that you're trying to produce, and they go all through the muscle. Whereas with a peripheral stimulation, we're probably often not getting access to all the motor units, or maybe just accessing ones that are underneath where the electrodes are. So that's probably the other reason why you get more fatigue with electrical stim as well too, because you're probably just chugging away really hard with some motor units, but not kind of like sharing the load across all the motor units of the muscle. So moving electrodes is sometimes then a good strategy for if you just are not getting an effective stim anymore. Sometimes just increasing the intensity, if somebody can have the intensity up a bit stronger, will help to then recruit more motor units. So that's just to give you an awareness of why fatigue is different with electrical stim. Now, the other parameters we're going to look at are these, and we're going to think about why you would change them in various different types of application of electrical stim. Okay, to start with the waveform. Okay, and I think this is really important information because it kind of comes back to Lisa's question, which I think is largely about, how safe is this? And some people, particularly if you work with older therapists, used to sometimes stimulate muscles with direct current. And I don't think there's any machines like that around anymore because they're not very safe. What these machines, these small machines that we can buy easily now use is they use an alternating current. And the principle of that is that when you have a direct current, you can have an accumulation of ions in the tissues, and so you can then get tissue damage. When you have an alternating current, you have ions flowing one direction and then the other. And so the principle of that is that you don't get an accumulation of ions that can cause tissue damage. So these are what's called an alternating biphasic current. Most of these machines, my understanding, are an asymmetrical biphasic current, which means that you have that you do not cause damage. Okay, so I think that's a very important concept for us to understand, and particularly when you're talking to people who have got experience of other types of current, so which I think were probably quite effective, but maybe not quite so safe. It's not direct current, it's not interferential current either, which sometimes people associate with being able to cause tissue damage. It's this biphasic asymmetrical current, like on this bottom part of the screen here. The pulse width now, so if we think about, we have this biphasic current, so it moves in one direction then the other, and the length of that pulse is the pulse width. Okay, the pulse width is related to stimulating the types of nerves that we want to stimulate, and so what you see on this graph is that if you have it, so we've got amplitude, which is the intensity of the current, and we've got pulse duration down the bottom here, is that you have a kind of an ideal range of the pulse width, where if you take it down much lower, so if you go much lower than here, you're going to start to get a lot more of your pain nerves. But if you take it up too much higher, it's not that useful because you only stimulate in the sort of the beginning part of the pulse anyway. So the general principle there is that often shorter pulses feel a bit more comfortable because we're not going short enough to be into the bit that is going to get more pain nerves. But there is also a principle too, where sometimes being a bit longer allows the current to go a bit deeper. So sometimes, but not too long. So the machine, this machine that I'm using here, allows a pulse width that sits between 50 and 450 microseconds. I'm pretty sure I've got the right value there. So the reason it's chosen that range from 50 to 450 is because that's this kind of ideal part of the pulse width where we're going to get our motor nerves without doing too much pain and other stuff. Okay, so that's the width of the pulse. Now we're talking about the frequency. So this is how many pulses per second. So this is in hertz now we're talking about. And this is important because different frequencies stimulate different types of nerves. So when we're thinking about TENS, which is the type of electrical stim that is applied for pain relief, that tends to be a sensory stimulation, which is a much lower frequency. It's generally thought that to get an effective motor stimulation, you need a frequency greater than 30 hertz. So most of these machines that we're using will set them somewhere between 30 and 100 hertz. There is also a principle that using the lower end of this frequency is going to stimulate type 1 motor units more, and an upper end of this frequency is going to stimulate type 2 motor units more. So again, we might think about how we might change the frequency for different types of application, and we'll come back and look at that. Now we have the duty cycle, and that is another thing that we will set on the machine, is the duty cycle. So so you have an on time and an off time, a work and a rest cycle, and you have a ramp up until you get to the maximum intensity that you've set, and then a ramp down. So ramp up on at its maximum intensity, ramp down, and then a rest time. And you'll change that according to the purpose of the ES or FES. And we'll talk about this a bit more when we talk about sort of setting it up, particularly for strength, for example. Okay, now we're thinking about the intensity. How strong is the current? And this is the thing that we adjust once we put the machine on, because all of those other parameters you can set before you put the machine on. But once you put the machine on, you put the electrodes on, then you will turn up the intensity. And so when we think about intensity, we want an intensity that gives us muscle activity that reaches a tetanic contraction. And what you will often see as you turn up the intensity is that you're getting some twitches. And what's happening with twitches is you're getting these individual motor units firing, but you're not getting enough motor units to get a smooth contraction. So you'll sometimes see that. You particularly sometimes see it, when you're setting up the shoulder sim with your triceps. So you particularly see it sometimes at posterior deltoid and triceps, where you just see this twitch, 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 and then you turn it up a bit stronger, and then you get a tetanic, a smooth muscle contraction. But you don't want to keep turning it up. You don't want to get to the pain bit. So it's that kind of balance between trying to get to a tetanic contraction and not get pain. And this is a very, very individual thing. I teach these classes to the physio students, and some of them, they're squealing when it's like at 6 milliamps. And then some of them are like whacking it up to 40 milliamps and going, yeah, that's all right. It's a very, very individual thing. And I think one of the things that has convinced me a fair bit about the safety of these machines is that I'm teaching 20-year-old physio students, and the guys will get a bit competitive and turn it up to its maximum intensity and think that it's a great joke, and so they're turning it up as strong as it can possibly go. And so it depends on the resistance and just how sensitive you are to the sensation. You will get more motor units as you continue to turn it up. But you can also sometimes turn it up and then you get spread across to other muscles. So you can overdo it as well. Now, I'm not going to answer all these questions here. The purpose for this slide really is for people listening to the lecture recording is to to check your understanding of everything that I've just talked about. You might like to, I don't know if anybody here wants to come back and check the lecture recording, but it's just like a self-test quiz. We're going to now apply the electrical stim, but maybe before I go into that, maybe I should just stop and see if there's any questions.
Yes, Simone, there's a few questions around the shoulder subluxation. In fact, 3 or 4 people have asked the same question. They've asked if the person develops subluxation. I mean, obviously we'd like to apply the stimulation early, but if the person has developed it, is it still worth using the shoulder subluxation procedures?
According to that evidence and the guideline from the Stroke Foundation, they're suggesting to use it within the first 6 months after stroke to either to prevent or treat subluxation. So, I haven't explored that evidence further, but I'm assuming that is because they're within that maybe there is some evidence that it can also help to reduce subluxation. Or maybe they put it in there to make sure that people still do it to prevent subluxation getting worse. I'm not, and I don't know if the evidence is that clear. So I'm sorry, I can't really fully answer that question.
Thanks, Simone.
If you go back to the guideline, it's really sort of 6 months, whether it is for prevention or management of subluxation.
Thanks, Simone. And then people are interested in the concept of damage. Do you feel that increasing the intensity can do damage, or do you think this is a fairly safe intervention? You've mentioned previously you thought it was fairly safe.
Yes, I really believe it is very safe. I think you can hurt yourself if you turn it up really strong and it hurts. The worst I've ever seen is a bit of skin reaction, and I think where you get a skin reaction, it's skin reaction to, you've got these electrodes, and they've got this, this gel to the gel to help it stick onto the skin, and sometimes people have a bit of a skin reaction to that, and so I think that's the sort of thing that you need to look for. But I think when you look at the physiology behind these machines, there's not really a way for them to do tissue damage. So I do think they are very safe machines. And I think the other thing that we should be reassured by is that, people can go out and buy these machines without any medical advice. You can buy them on late night shopping with a free set of steak knives, and I think a lot of those machines are probably not like these ones that are being produced to be bought by people in clinical settings. I actually have had some experience of when I worked in traumatic brain injury. One of the traumatic brain injury survivors, her sister had bought a machine for her, and literally she did buy it late night shopping. I don't know if she got the free set of steak knives, but she bought it on a sort of a shopping trolley, and that machine was way stronger. It was really a super duper machine. It was so effective, but it seemed to be way stronger than our little safe medical supply company machines that we were using, and I'm assuming it was safe as well too. But I think we can be confident in their safety. Yes.
Simone, there's a couple of interesting questions about applications you've shown already. Someone's asking where you place the electrodes in the hypothena video that you showed. Where were the 2 electrodes placed? And another person's asking, have you tried electrical stimulation for lateral shoulder movement, and do you find that it works? Lateral shoulder rotation, and do you find that it works?
Or external rotation?
External rotation, yeah.
Yes. No, but I think I'm a bit crap at that one, because I know Carl Schur can get external rotation of the shoulder, and you might notice I haven't put it in this presentation because I've never been very successful at getting it. So I know people do manage to get external rotation, but I'm only putting in the stuff that I feel is relatively easy to do and not too fiddly, basically.
That's interesting because that's what the questioner was asking. They said they found that movement very difficult to stimulate as well.
Yes, I'm glad I'm not the only one. Yes, and so the question about the thenar and hypothenar eminence is that I think I mean, and my understanding might not be accurate, but my understanding is when we stimulate the thenar and the hypothenar eminence, that really would just, it's really just the one electrode that's actually doing the work. And that you notice with the, I'm not sure with the hypothenar eminence where, and that setup where the extras, I think the extra electrode was just up here somewhere. But what you tend to do with the thenar eminence is you have one here, and then you just put one here, and you're basically putting it over bone and tendon. And it's really this electrode that's really giving you the stimulation that you want. So I think it's the same with the hypothenar, that you're putting it on the hypothenar eminence, and then just the other stimulation. And I should also point out that with these machines, this machine, there in the instructions, I can't see the chords here, but in the instructions it suggests that the electrode, that's the black lead, there's a black lead and a red lead, and the black lead is the most active electrode. So in that instance, and so that's where I think you just need read the manual of the machine you're using, or check if you can get some advice on that. But for this little machine, the suggestion is that you put the black electrode in the most sort of active spot, if you like.
That was a question that had come in on the forum, actually. Simone, so fantastic, you answered it. An interesting one that's come in is about stimulating stronger muscles, Simone. So people are asking, are you just referring to weak muscles here? What about grade 4 out of 5 muscles? What are you suggesting here? Is this a whole different seminar, I think, maybe?
I'm suggesting why bother? I'm suggesting if somebody's got that much strength, then there's much better ways to go around making them stronger than fiddling around with electrical stim. If somebody's got grade 4, they can do progressive resistance training, and that's and Joe, isn't that your clinical trial? do you want to mention that?
We in the different populations, we have looked at that within clinical trials, but I agree with you wholeheartedly, Simone. If someone's got grade 4 muscle strength, we'd use progressive resistance exercise as well.
Yeah. And they can do more interesting things too. Maybe you can combine some progressive resistance training into tasks, load them up in their sit to stand and things too, or so I think its role is really in the very weak muscles, where we're really, really struggling after stroke, to help people with those grade 1, 0, 1 and 2 muscle strength, particularly 0 and 1. It's surely our most difficult job in stroke rehab, is to increase strength in those muscles. Shall I keep going?
There's a lot of questions.
Okay, well maybe we'll just power on a bit, Joe, I think. Okay, so application. So we're thinking now about the application, and this is what we're going to have a look at. So I'm using these APA guidelines, which are very old, but just because I think they are the most sensible. And I did have it in the preparation of this lecture, have a bit of a scout around. There are some quite comprehensive guidelines from a Canadian physiotherapy group, but I don't understand the reasoning behind all of their guidelines. I just think these ones are very sensible. So in these ones, it's contraindicated over the uterus in pregnancy, or over like a cardiac pacemaker. But that's it's kind of in those areas. And then everything else is a precaution. And so I think we can just make very sensible decisions around those precautions. And so somebody's got tumors or skin conditions or anything else that you're worried about, just don't do it in that area, but maybe you can do it in other areas. And you'll notice, I think particularly importantly for stroke here, is that people who are unable to communicate or have sensory loss, it's a precaution. It's not a contraindication. And so you would do just the kind of sensible things. If they can't communicate with you well, just look at their face and see if they're uncomfortable. If they've got sensory loss, then just take a lot of care with it, and particularly check the skin after you remove it afterwards, to check that they're not getting a skin reaction. But they are precautions, not contraindications. The suggested warning to be given within those guidelines is very long. so I think you probably want to summarize that a little bit, because you imagine a lot of people, you might have lost them after the first little bit of that, and particularly if they've got any receptive language problems. So I think it's more just, it shouldn't be too uncomfortable. Just, let me know if it's getting too uncomfortable. I think you try and avoid words like, that we're going to make people anticipate pain. So don't, turn it up and go, is it hurting? Is it hurting? Is it painful? Is it painful? So be careful what you say. And pain is obvious when people are in pain. So I think just, be sensible. In terms of skin prep, some people do apply it over broken areas of skin using Vaseline, but I think if you want to be a bit more careful, maybe you just would avoid broken areas of skin. This is particularly if you're having trouble getting stimulation, you can be very careful with your skin prep. I'd have to say that I never bother doing skin prep on the whole. I was having a chat with Carl Sharon and saying, yeah, I never do skin prep. So I think you can just whack it on, and if it's working fine, then that's fine. But you can also, if it's not working that well, really do more careful skin prep, because more careful skin prep will mean there's less resistance and the current is just getting through more easily without necessarily having to turn it up more strongly. So okay, and then now we're thinking about where to put the electrodes. Now, what you can find in terms of electrode placement, and you can just Google it on the net, is you can find these diagrams of what's called the motor point. And the motor point of a muscle is where you've got most entry of motor nerves into the muscle. And generally, as a kind of a very rough rule of thumb, it's often thought to sit roughly about 1/3. Yes, you've got a muscle, proximal end, distal end, about 1/3 away from the proximal end of the muscle, but that's a kind of a very rough thing. The motor point for tibant sort of sits just underneath the fibular head. So that's sometimes helpful when you're trying to get tibialis anterior, but we're in the upper limb, so I'll stick to upper limb. Anyway, so as a general rule, and if you've got a machine like these ones where you've got the black electrode is the more active one, that probably makes more sense for that one to be more proximal, what might be a sort of something around the motor point of the muscle, and then the other one to be distal, so that you're covering a lot of muscle belly, but not so far down that you're starting to put it on tendons too much. Okay, so if you're thinking about wrist extensors and stuff, you might put your proximal one sort of up around here and your distal one sort of around here. So you're covering a fair bit of muscle belly there. So the suggestion is to put them as sort of far apart as you can, still covering a reasonable amount of muscle belly. Okay, now what to do when you're having trouble getting a decent contraction? Improve your skin prep, or if you're Simone or Carl, maybe go and do some skin prep in the first instance to minimize resistance. You can add in gel. So even though these sticky electrodes, they do have some gel, sometimes, and particularly sometimes you're reusing them on, they're getting a little bit old, adding just, some more ultrasound gel sometimes helps to get a bit more, flow of current from the electrode to the skin. You can go back and check your stimulation parameters. And so what you can do, and what I suggest, and I've got sort of a summary slide at the end, is if you have not done a lot of electrical stim and you're really trying to use more electrical stim clinically, is go and have a really good play with it and see what happens when you change some of the parameters. So you can, when you think about what we said about pulse width, sometimes making it lower down the lower end might be more comfortable, but sometimes putting it up the higher end can mean a more deeper stim. So you might change the pulse width to check how that changes the effectiveness of the stimulation. If it's mainly comfort, that's the person just does not want you to turn up the intensity anymore, then maybe it makes sense to bring the pulse width down a bit lower. You can increase the ramp time, so they're not getting a sudden stimulation, so they're getting a slower build up to the maximum intensity. And these other, and I guess the other thing to make note of is that better skin contact and less resistance between the electrode and the skin will make it more comfortable. So sometimes that kind of work that you might do to get better contact between the electrode and the skin might actually increase the comfort, so that then you can increase the intensity. The electrodes as well too. So sometimes using, these are quite much larger electrodes, but they would be too large, like for my arm here. But they might work for me for triceps and cover a lot of my triceps, for example. So sometimes the larger electrodes might help. You can play around with the position of the electrodes. And sometimes you can do, and this happens, I think, particularly with floppy kind of muscle. So if you think about your triceps is a bit of a floppy muscle, even though I do big camp, mine's still a bit floppy. And so what you could do there to get better contact is actually you put the electrodes on and then you get a great bandage and bandage the electrodes to the arm, so that you've got better contact between the electrodes actually and the muscle there. Yes, and check your machine instructions, see if you've got, I must admit, I've been using these machines for a long time before I realized that the black electrode was more active. So check that so that you know that. There's a problem that sometimes happens with the machine. I'll just show you an example of it. So see how you're getting, so see how it's flashing there. And so what's happening is somebody's trying to increase the intensity and they're just getting a flashing of the machine, and other machines might have some other variation of this, or sometimes you only it gets to 6 milliamps, which is a very low intensity, won't go any higher, or goes up to 20 and then jumps back to 0. If it's not letting you turn up the intensity, it is usually because the machine has decided there's not enough contact between the electrodes and the skin. So go back and check the contact between the electrodes and the skin and make that better, and then the machine will be happy to turn up the intensity more. Okay, so we have these parameters that we can manipulate, and we're going to have a look at some of the common applications and think about what makes sense in terms of manipulating some of these parameters to make the electrical stim as effective as possible. So if we're thinking about increasing strength, okay, so we might be wanting to follow a bit of a principle of really tiring that muscle out. And so maybe it makes more sense to go sort of higher frequencies and do more type 2. But then if you're getting such short treatment sessions and the muscle's fatiguing, then maybe you might want to decrease. So it depends a bit what's happening in that treatment session. But if somebody's quite happily and they just keep working away and then they can do it for half an hour, then maybe a higher frequency might be good in terms of targeting more type 2. And type 2 motor units are more disadvantaged after stroke. You lose more of your type 2 motor units after stroke. Adjust the ramp up and down. So think about the ramp up and down. If you've got somebody there really and you're asking them to work with the machine, what might make sense would be to have quite a long ramp up and a long ramp down, so that machine's not kicking in very quickly. So they can really think about trying to pick up with the machine, and that when the stimulation goes off, maybe the stimulation goes off over 2 or 3 seconds. So it doesn't just go off, goes off slowly. And as the machine is slowly turning down the stimulation, they try and hold their hand up. So those kind of things that maybe could be very helpful with increasing voluntary activation. So there's a kind of a summary there of some of those principles when we're thinking about the main aim of treatment is increasing strength. Well, we didn't talk about on-off time, but you might have something sort of fairly even, sort of like work for a period of time, have a bit of reasonable rest. Might depend a little bit on the stroke survivor. Maybe too much rest time is they're going to get distracted, or so it might be a bit individual there. If you're using a EMG triggered or position triggered, then obviously you're going to go for the person working as hard as they can, whether that's EMG or getting to that position, or to get the trigger. If they are fatiguing, as we've mentioned, if they're fatiguing a lot too early, you can move the electrodes to stimulate different motor units. Okay, so if we think about FES, functional electrical stim, then it's going to depend a bit what kind of machine you've got. But if you think about often with tasks, you don't want a slow ramp up. You want things to come on quickly, because most things that we do, we don't wait for 2 seconds to extend our wrist. We do things quickly. So you're going to have sort of probably a very low ramp time, or almost no ramp, maybe. If you've got a hand trigger device, that's probably going to be very useful. So the person really tries to produce it, and then the stim comes in to help as much as possible. So if we're thinking about this really in the context of increasing activity, functional electrical stim, the ramp up and down probably specific to the task. Again, how long you want the stim to be on for, specific to the task. If you're using these, then basically you hold it on for as long as it needs to be on, and then you release and it goes off. So that's where that's very useful. Again, threshold would be where you are getting the maximum work that the person can do. And if we're thinking about activity, if we're thinking about skill acquisition here, then you want hundreds and hundreds of reps of practice, because that's what people need to do for skill acquisition, for neural plasticity that improves their function. Shoulder subluxation. So here we are, we're back in shoulder subluxation. So here it makes most sense for, as we mentioned earlier, for that application to be on all day, really, because we're using it to try and provide that sort of external support to the shoulder joint. So you probably want it to be comfortable. It probably makes sense to have it sitting around 30 hertz, because that's where we're thinking that you're going to get more type 1 motor units, which are your more fatigue resistant, and you want it on for a long time. You probably don't want a really quick ramp up and down, because it's particularly ramp down. You probably don't want it to sort of drop off suddenly. So some machines, this machine, you can individually adjust the ramp up and the ramp down. Some machines, the ramp down is set at the same as the ramp up. So you just have to have a look at your machine instructions there. The treatment time makes sense that it's really on all day when that person is upright and their shoulders in a more dependent position. So that's a sort of a summary of some of those principles. And if you go back and have a look at the studies that have been done around shoulder subluxation, they sometimes start with a lower sort of on-off time, but they generally work up to having a very long on time compared to the off time, because it makes sense that you want it on as much as possible, supporting the shoulder joint. Now, just a brief word, because, and particularly Annie McCluskey is concerned that sometimes occupational therapists feel that this is not within their scope of practice. So I've just pulled out, this is out of the Australian Physio and OT Code of Conduct guidelines from our Allied Health Practitioner Regulation Authority. And so what it tells us is that we can do things as long as we are sort of adequately skilled to do them. So sufficient training, you don't need to go off and do a course. Sufficient training is take your machine and figure out how to use your machine and start using it, because they are very safe machines. There's very few electrical stim workshops that run in Australia, unfortunately. But anyway, but I don't think you need a workshop. I think it's a pretty straightforward kind of application. But it certainly falls within our code of conduct if you kind of just are aware of what you're doing. And I think what we have to be very, very aware of is that these typical ES machines are not using currents that can cause skin damage. It's Annie says that it's probably only about half of the occupational therapy courses within Australia that teach electrical stim to the occupational therapist. So that's a real shame because we do have evidence for this application. I think that probably most physio courses do teach it on a physiotherapy course. But if you're an occupational therapist, there are some, and if you do the StrokeEd upper limb workshop, for example, that contains some electrical stim practice within that workshop, or you might be able to find some specific electrical stim workshops. But just practicing with the machines and getting familiar with the machines, I think is enough. And hopefully that's as long as that gives you enough confidence. But they are safe, so go ahead and do it. Okay, in summary, we have looked at electrical stim for strength, activity, subluxation, hand swelling with the dual channel, and shoulder pain with some of the ones that we've looked at and discussed the evidence of. We haven't gone into all full details of all of those, but we've gone into more detail for some of the more common applications. Have a basic understanding of the parameters so that you know how to make it work as best as possible, and so that you're applying that sort of clinical reasoning to what is going to be the most effective for the purpose of the stimulation that you're using it for. And go and take the machine and just practice on yourself. Take it home, practice on your family, so that you feel familiar and confident with it. And so if anybody wants the references, maybe I'll just go through them a bit slowly. You could take a screenshot or a photo or something. There's 3 slides of references there. So there's the one you got. Hopefully you got that if you want that. Or as Joe said, we will have this lecture recording up there. That's the 2nd slide of references, and that's the 3rd slide of references. So I'll stop screen sharing, and if there's some questions, I'm happy to take some more questions.
There is a few more questions in the Q&A, Simone. Yep. A couple that I'll post to you that seem particularly interesting. One person's asking about Kathy Sleer's research with the upper limb and asking about what you recommend for the use of ES in chronic stroke survivors.
Oh. Yes, I think the Kathy Sleer's prediction stuff, it is very interesting because it tells us a lot, but it still doesn't tell us about everybody. And I think that does really come down to the individual stroke survivor, and sharing information with them. And if people want to keep plugging away for years working on their arm, then we should be providing them the means to do that. So I think some of the studies are done in people that are quite chronic after stroke as well too. So there is a bit of a mixture in the evidence across acute and chronic populations. So we do have some evidence as well in more chronic populations, particularly some of the early electrical stim work. A lot of that was done in people quite late after stroke. So we can get change late after stroke, but it probably is dependent again on reasonably high dosages of practice. If you've got people with very, very weak muscles, doing everything you can to try and get them to voluntarily activate alongside the machine as well too.
So there was an interesting question. What's your opinion on someone who can't tolerate a high intensity? What's your opinion on low intensity stimulation that doesn't actually generate a decent contraction? What do you think about that?
Hard to know, isn't it? Yeah, I wouldn't have thought it's probably doing very much, to be honest. And I think and there are some people who are just really sensitive to it. I think we've gone through a bit of a range of things you can try there. Playing around with the pulse width, doing best skin prep, making sure you've got really, really good contact between your electrodes and the skin. If you've done all of those things and somebody really, really hates the stimulation, then I think there are other things. Have a look at the StrokeEd resources. There's a bit of a range of other things that you can use for very weak upper limbs, as well as electrical stim.
Simone, a few people in the chat were interested in your mention of gel. Do you recommend using gel under the electrodes, or what are your thoughts around that?
No, not generally, just as an extra tool if you want something to, which again might make it a bit more comfortable for somebody who's finding it more uncomfortable. To be honest, we sometimes used to use gel because sometimes we had such old daggy electrodes that we could, so the hospital wasn't buying us anymore, and so it was kind of like probably just extending the life of our old daggy electrodes. The other thing that you can use gel for is if you've got, imagine I've got a sticky electrode here, and so it's really quite stuck to my skin. But if I have gel and I can slide it around a little bit, and if I'm having trouble finding the best position for the electrode, if you actually, and sometimes you can get these ones that aren't adhesive electrodes, or sometimes what you can do is you can rip the sticky stuff off them so that you just have like a rubber electrode, and then you just use a rubber electrode just with the gel. And what you can do then is you can move while the stimulation's on, you can move the electrode around a bit to find the best position for the electrode. I must admit, I haven't done that so much in the upper limb, but I found that very useful in the lower limb, because sometimes I can find it quite hard to get dorsiflexion in the lower limb. So that's where I've used that a bit more as a strategy. But this is an upper limb lecture, so we won't talk about it.
Simone, it's starting to get later. Would you like to keep answering questions, or how would you like to proceed?
Let's go 3 minutes, Jo. 7:30. Do you reckon?
We'll do it. I think we can do a few more questions here. This is an interesting one, Simone. Someone's asked, and they asked this a fair while ago when you were talking about the EMG triggered stimulation. How do you manage when that's not triggered by the movement you particularly want? So if it's triggered by that, they're asking compensatory movements. Do you have experience with that?
Yeah. So yes, I mean, and ideally you want the EMG, whatever whatever machine you're using, you really want it to be reading muscle activity that's happening in that muscle. And so then I think, you really have to be careful with your instructions to your stroke survivor about trying to relax everything else, and really just work that muscle, so that to get the trigger, if you can. And if you, and I know, because I have spent a bit of time using EMG triggered, and sometimes it is very, very tricky, and sometimes it's tricky when people are very, very weak to distinguish between what's noise, and from them wiggling, and because people are trying really hard to do something with very weak muscles, and so other things are happening, and kind of that's understandable. So I think if you as best you can, trying to get them to relax other things and not use other things, and trying to figure out what's noise from other stuff and what is electrical activity in that muscle. We generally had decided that with the machine that we were using, anything under 5 microvolts measurement of EMG activity could quite easily be noise. It had to be generally more than at least 5 microvolts. That was with a specific machine we were using for us to be confident that it was electrical activity coming from that muscle. But that is very tricky. I agree, and particularly in very weak muscles where people are, like they're just working hard and doing other stuff sometimes. So,
Simone, there were quite a few people concerned about the slight redness that people get with the application of electrical stimulation. Have you experienced that, and are you concerned about it?
Only if it hangs around. Hangs around. If it's a little bit of redness that goes away within, I don't know, would you put a time frame on it? I don't know, but if it's gone within 30 or 60 minutes, then if it's just a small reaction, I wouldn't be that worried about it. But if it hangs around longer, and if their skin is uncomfortable or irritated, then I'll definitely be worried.
I think I'd agree there, Simone. Simone, there's so many great questions in here and so much interest in ES. One particular one that might be good to finish on. People are saying that they're combining active effort with the electrical stimulation, but asking your opinion, what happens when the person gets fatigued or doesn't participate with the stimulation? Do you keep going for the prolonged periods, or what's your suggestion here?
Yeah, it's a tricky question, I think, isn't it, Joe? Because, you know, when you think about a lot of those studies that have been done just looking at cyclical electrical stimulation, a lot of them, there isn't really an indication that they're necessarily doing a lot to try and get the person voluntarily activating their muscle along with the electrical stim. I mean, we're suggesting that because it makes sense to do that. So it does appear that there maybe is some benefit just from having it as a pain peripheral stim, but I think we, you know, you still kind of really want to maximize people working with the stim as much as possible. And so maybe going for shorter, you know, maybe give somebody a 5-minute break, or switch, from muscle to muscle a little bit, go do something else. You know, turn the machine off, do 10 sit to stands, you know, if they can sit to stand, just activate their brain a bit. Again, so, you know, any I guess any of the normal strategies that you'd use to try when people's attention is lagging, really.
That might be a great place to finish, Simone. You're getting lots of comments in the chat thanking you for such a clinically useful presentation. I feel the same. It's a really, you've given so many strategies which people can go away tomorrow and use this as electrical stimulation. So thank you so much for your presentation, Simone, and I'll leave you with the closing comments.
Thank you very much, Joe. And just feel free to send emails through to the StrokeEd email if you've got questions and things too. Thanks, Joe.
Bye for now. Good night, everyone. Thank you very much for listening.
Bye, everybody. Bye.